let me say first that it's really an honor for me to be here, and also a pleasure. This is my first time here in Korea, and I'm already really impressed by everything that I've seen, including many restaurants and meeting many very nice people. Fortunately, most of them we have already met in Lausanne this summer. And now I'm very happy to meet all the rest of this wonderful endeavor that you have started some time ago. And I'm really grateful that I can say we, as visitors here, are allowed and hopefully able to contribute to your effort in implementing shared decision-making here in Korea. What I'd like to do first here today is to give you some ideas about research studies on shared decision-making. And what I'd really like to do is to lay a groundwork for discussion together, because in the beginning we don't know each other, and we are sitting on long tables here and haven't talked much. I hope this changes, and I really invite you to ask questions, and I hope I will be able to provide enough time for your questions and also have some answers for you. When preparing these slides, I was thinking about what is on your mind, or what was on the mind of the organizers when they said, let's put this topic on the agenda. And what I remember is when I work with my students or with my team members, the first question, often you are advised to conduct an STM study. And this sounds very easy, but if it comes to the details, of course, it's quite tricky. And I listed some questions here, like, okay, let's conduct an STM study, but in which setting? And should we go disease specific? Or what is the subject of our intervention? Are we talking about patients, or doctors, or nurses, or physiotherapists, or something completely different? What are the interventions that we'd like to employ? Trainings, decision aids, something completely different? Who are the participants? I mean, it depends. Who are the participants depends on what were your answers to the questions before. And next question, what about an appropriate sample size? How many people or subjects do you need? What about the outcomes? And since you listen to me, you can see that every question leads to different answers in the next step. And this goes on. If you know what outcomes you are interested in, then of course the next question is, which measures should you choose? And what about a control group? Is it necessary? Is it even possible? And if you have a control group, are you able to blind the concealment or conceal the allocation to the groups so that the participants know if they are in the intervention group or in the control group? Is this possible? And is this allowed from an ethical standpoint? And is it appropriate to have a control group at all? Or should you make sure that everybody gets in touch with your wonderful new intervention? So you better not have a control group at all. And where do you get the money from? And should you have patients on your board when planning studies? And maybe also politicians? And maybe also payers, like members from health insurance companies? So many, many questions, and I'm sure I won't have the answer to every question for every research subject that you are interested in. But I'd like to give you some advice, some ideas, some guidance how to approach these questions depending on your particular research question, research field. And I'd like to give you some operationalizations, how you can do this, some examples, of course, only. And I'll show you some links where you find more resources so that you can work further after this workshop. And as I said, I hope I will have time for questions from your side. When you approach these questions, I guess the most important overarching question is always, what is your aim? And this is basically the question that I always ask my students when they begin planning a study, and they are delving right into the details already from the beginning. And I said, wait, one step back. What is your aim? And they say, oh, this and that. Yeah, but more generally and more specific, what is your aim? What do you want to achieve? Why are you doing what you are doing? So, to answer this overall question, I'd like to give you an idea how your idea of what shared decision making is and why it is justified to do it influences how you answer this question. Yesterday we had a meeting with a journalist, and we were asked, why are you doing shared decision making? What is your motivation for doing shared decision making? And one answer that we gave was, we believe that shared decision making is a value in itself. It is justified by ethical considerations already. Later, I was thinking again about this answer, and I was wondering if you would say the same with your ethical background. At least I can say that this is my standpoint in Germany, or I can say in Europe, I guess, that shared decision making is justified from an ethical standpoint already. And you may agree. If you call shared decision making a value in itself, then you may think, okay, so we should do several different things. We should invest time and effort to produce and enhance shared decision making. Like, for example, train doctors or develop decision aids or train nurses or whatever. If you do this, and if this is your understanding of shared decision making, then you may call these the interventions, and then shared decision making is the outcome of your intervention. So far, so simple. But you may also have another idea of shared decision making, of your aim when introducing shared decision making. I mean, you're planning to have a rollout of shared decision making in your entire country. So it's good to ask, why do you want to have this? From an ethical standpoint? From an ethical standpoint only? Or also motivated by other considerations, like, for example, are you convinced that shared decision making is a vehicle to improve healthcare? I am, by the way. But it depends if you see shared decision making also in this way, or if you say, well, I don't care about any influence on the quality or costs of care, because shared decision making is justified by itself, and I don't care about the consequences. But if you think of shared decision making as a vehicle or a measure to improve healthcare, then you may not talk about shared decision making as an outcome, but instead you may talk about shared decision making as the intervention to improve healthcare, which is then the outcome. But if you have shifted somehow the labels to the right, then you need to find a new word for your previously called interventions, and you may call them an implementation strategy or implementation elements combined to an overall implementation strategy. If you think this is what I do, and this is how I think about shared decision making, then you are in line with this new study by Marla Kleiman and colleagues. And you can find everything in your wonderful booklet, and you can scan the QR code. Everything that I show you is open access, so you can read the papers later on. However, one step back, because this is the part that I guess most of you are interested in, and we will talk later about outcomes in terms of healthcare. So one step back. If you think we should increase the level of shared decision making, and I guess everybody here agrees, then the next question is, okay, how do we know that we have increased or maybe have failed to increase shared decision making? What are the outcomes to measure to find out if we were successful or not so successful? Well, a good next thing to do is to really think about what is shared decision making. How do I operationalize shared decision making? If this is the subject we are all working on, we should be very clear, or as clear as possible, what we are currently dealing with, you know? And another source of information in this regard is this wonderful review. And here are many models of shared decision making being discussed. And in this moment, I'm talking about a model as a theoretical construction. I learned that here in Korea, the word model is used in different ways. In this case, I'm talking about a theoretical concept of shared decision making. In our case, the work that we do, we refer to the integrative model of shared decision making, published by McCool and Kleiman already several years ago. It was 2006 already. And this was our starting point for our definition of shared decision making. However, and this was already a review of the work that had been published back then. However, this is still not a practical model. This is still a theoretical concept, I would say. And this is not something that you can work with when you work with doctors or nurses or patients. So what we needed was a translation of this theoretical concept into a practicable model. And what we came up with was our 6-step model of shared decision making. And what you see here are 6 steps that you ideally go through when doing shared decision making in practice between doctor and patient, maybe including family members or other people, and maybe also including nurses and other medical professionals. So first you define that today a decision has to be made, and then you explain why it is important to get your patient engaged in this decision-making process. And this is because there are more than one options available, and it depends on the patient's preferences which of these options is the one option that fits best to the patient's preferences and needs and personal circumstances. So this is the starting point. We also call it the key message of shared decision making. The starting point, the very justification why shared decision making needs to happen. There's more than one option, and it depends on the patient's preferences which of these options fits best. And if this is the case, of course, you need to integrate the medical information on the one hand and these preferences, the personal preferences of the patient on the other hand, into the decision-making process. And these 2 chapters or 2 steps are on the same level here because it's typically a back and forth between the 2 of them. And it doesn't really matter if you start with this and then switch over to the personal preferences, or you do it the other way around. This is why we have aligned them here on the same level. But if you have discussed the medical reasons, or the medical pros and cons and the personal pros and cons, then you may make a decision, or you may decide to defer the decision and then put this decision into practice. So if you are really do good work on this level, then the rest is easy. This is our 6-step model. And you can look at it. It's on page 10 in your booklet. When I will talk about it later, so you can read what's the typical thing to say for each step. This is our definition of shared decision making, and of course having a good and clear definition of shared decision making is a basis for choosing a measure for shared decision making. And in our case, if this is our definition of shared decision making, the theoretical definition and the practical definition, then it's quite easy. You need an instrument that captures exactly this. And fortunately, in our case, we have a measure that captures exactly these 6 steps, and this is MapIn-SDM. And I know that you have, some of you have, where are you here? That some of you have chosen MapIn-SDM to capture the level of shared decision making that is happening in a consultation. This is not the only instrument that you can use, but the connection between the theoretical side here and the measurement side and the practical implementation of shared decision making is the reason why we prefer MapIn-SDM as our outcome measure. So you have a link between theory, practice, and measurement. However, we have published a paper that we have termed 6 steps of STM, linking theory to practice, measurement, and implementation. And here comes the practical part that you are working on. How is this related to implementation? Well, coming back to this slide again, what we really do is, when we say we want to produce shared decision making, is we want to see these 6 steps happening in practice as good as possible, as often as possible, and most of them as often as possible. You will never be perfect, but it's the ideal that we want to come as close as possible to. Okay? And for example, if you look at these middle part, the medical pros and cons on the one hand and the personal preferences on the other hand, of course, you may choose to use a decision aid to inform patients about the medical pros and cons and to elicit the personal preferences. However, if you train doctors, you may have the same aim. And you may also train nurses to explain the medical pros and cons to the patient, or to elicit the personal preferences, or to work as a decision coach, applying a decision aid, and also focusing on steps 3 and 4. And you may also have question promptlets or whatever. And this is why we often call this agent agnostic, which means it is not self-evident which person you address or which intervention you apply to increase, for example, the occurrence of step 3 and 4. You have to choose what you think is most efficient and effective in your situation. So what we did when we comprised our intervention program, the Shared Care program, was we composed it in a way that we hope it produces in the end the 6 steps of shared decision making. And these are the 4 modules of the Shared Care program, and I will tell you about these a little bit more now and a little bit more if we have enough time later. So one part is evidence-based patient decision aids. It looks like this. It's online, and we include texts and graphics and video clips with doctors on the one hand and physiotherapists or nurses, if applicable to this particular situation, and patients on the other hand. And patients can access these decision aids wherever they are. And if you think about the 6 steps, then obviously the primary focus is medical pros and cons and patient preferences. And also this is a precondition to to make this decision, which is step 5. But the simple existence of a decision aid in your clinic or in your practice also makes a difference in terms of, okay, obviously there is a decision to be made. Okay, so step 1 is indirectly also supported by the simple existence of decision aids, the visible existence of decision aids. Then we, in addition, integrate nurses as decision coaches. They sit together with patients with a decision aid in their hand, in this case on a tablet, and they prepare the following consultation with a doctor. So they are enhancing the effect of the decision aid that we have discussed right before. And if you look at the 6 steps again, of course, you have again the same effect. But in addition, we also educate nurses about shared decision making itself and how they can support patients in shared decision making also between these rather official or planned meetings. Like if you do your nursing work, of course you talk to patients. When you are doing a new infusion, then of course you talk to each other. And this may also be used to encourage shared decision making and to encourage the patients to bring in their preferences. So nurses are really, really important people in this shared decision making process if we're talking about shared decision making in a hospital. And also they may realize, I don't know if it's possible to do in your healthcare system, but in the German healthcare system, you can make use of nurses who point to doctors who willingly or unwillingly omit to integrate the patient's preferences. If you have a nurse saying, sorry to interrupt, but has anybody asked the patient what he or she wants? This is a very important function of nurses in the overall medical process. And I've been trained as a psychologist and I've worked as a psycho-oncologist for like 10 to 15 years. And this was often my typical intervention. Sorry, has anybody asked the patient, does he really want it? Very easy, but very powerful. I always call it guerrilla shared decision making because it's kind of an undercover work that you do. And when we train physicians, in our case, we do it by an online training first. It's a tutorial that you can work through online, and it takes 1 hour. And afterwards, our physicians record a video of their own consultation, typical normal consultation, nothing artificial, and they get feedback. And this feedback is based on a prior analysis of this consultation with MapIn-STM. And based on our MapIn-STM evaluation, we give personal feedback, like what is already wonderful. Here's our trainer, and she has, in this case, one doctor in front of her. What you're already doing wonderful. Here, let's watch minute number 225. What you are already doing wonderful is how you explain the options to the patient. Look at this. And you watch it together. What seems to be a bit tricky when we look at minute 4 is, oh, here, I think the patient gets lost. So what has happened there? What can be done better? Okay, so this is how we delve into the consultation, and since it is the very consultation of this very doctor, it is immediately personal. It affects this doctor, and you have the power when training doctors, because you have a video recording, you know? Okay, and we systematically address all 6 steps in the training. So this covers every step. And then what we also do is activation of patients. And what we do is we have posters and video clips on websites and on screens in waiting room and everywhere else, and also here next to the ice cream parlor. And also what is integrated is the Ask 3 approach. I don't know if you are aware of this. We encourage patients to ask 3 questions, and the questions are: what are my options? What are the pros and cons of each option? And how likely are these pros and cons to occur in my case? And this is distributed via these roll-ups here, 1, 2, 3, or via flyers or whatever. Okay, and we also have them on screens in the bed and mostly everywhere. And this intervention covers mostly the first 4 steps. This, by the way, is a famous physician and comedian in Germany. You will not know him, and it's okay, but most German people know him. So this is our testimonial, who is helping us to convince patients and to attract patients when they enter our hospital. So altogether, you can see that we try to cover all of these steps with different interventions or implementation strategies in the other term. And as you can see, more or less every step is addressed, but the first 4 steps are addressed more than steps 5 and 6. And this is because step 5 and 6 are very easy. You don't need as much support to make this happen. This is why we focus on steps 1 to 4. And if this works good, then the rest is easy. Okay? So what is left? We have touched many different parts of shared decision-making research already. I hope you haven't felt it in a bad way, but you have recognized it, that we have talked about many different aspects already. We have talked about your implementation strategy, where you may put different intervention strategies into practice. And we've talked about what is our definition of shared decision-making. We have talked about having, for example, the Share to Care program, and you will hear more about the STM Host program from Denmark. And of course, there are many more ideas and many more modifications that you may decide to do. You don't need to copy the Share to Care program. Feel free to do whatever you like. But this is what we have talked about. And we have talked about measuring shared decision-making, for example, with MAP and STM. What we in addition do is we apply the Perceived Involvement in Care scale. This is a patient questionnaire, and there are several reasons why we chose exactly this measure and not, for example, the shared decision-making questionnaire or several other questionnaires. And we also use Collaborate because it's so short that it doesn't hurt. But I can tell you right away that we prefer the PICS scale for several reasons. Okay, so we have shared decision-making. And then we have talked about the improvement of care, the desired improvement of care. And before I tell you more about this, if you want to learn how we applied this, how we did this measurement, and also the implementation, you may want to read this paper. And it's also open access where everything is described. I don't tell you about the results today because I need to have some more news for tomorrow, okay? And if we look at the results in terms of improvement of care, what are the measures and the outcomes you may be interested in? Outcomes may be health literacy. Do you improve health literacy by shared decision making. Maybe you reduce decisional conflict. Maybe you don't, and maybe it's not a bad thing not to reduce decisional conflict. Maybe it's also a good idea to increase decisional conflict. Can be a discussion that you may have, because sometimes it's good to realize that every decision comes with pros and cons. So maybe decisional conflict for a while is a good thing, although it may not feel well. However, you may discuss about this. And what we are also addressing more and more is how shared decision making affects how doctors perceive their work. And if we can prove that shared decision making reduces the burnout rate among doctors, this would be a very powerful argument for further implementation. And then we are talking about costs. I will tell you more about this later, tomorrow, I'm sure. And resource use, and also the quality of care. Does shared decision making have an effect on the occurrence of emergencies? And does it have an effect of the occurrence of hospitalizations after having been discharged from the hospital? Okay, so these are some examples, and there are many more that you can discuss, but at least to give you an idea what can be measured as a consequence of the implementation of shared decision making. I will tell you more about these exact outcomes tomorrow. So, coming back to our starting point, I hope I have some time left. I don't know how we deal with the delay, but you will tell us how much time for discussion we have, so that you use the input that you just got, and we delve into an open discussion about all the questions that I've left out, and I hope that I can give you some more answers to this as well. Thank you for now.